My name is Lynn Simpson. I'm the co-director or co-chair for the Fetal Therapy Special Interest Group for the International Society of Prenatal Diagnosis. And we are really thrilled today to be interviewing Dr. Louise Wilkins-Haug, who is a professor of OBGYN at Harvard University. She's also the division director of maternal fetal medicine, as well as reproductive genetics at the Brigham and Women's. And I believe she is the current president of
I am. Thank you for the introduction.
of the International Society of Prenatal Diagnosis. And so one of our goals today is to really give an update on invasive fetal cardiology and where we're headed in the future. So first of all, I want to ask Louise, as part of the really well-known Boston's Children's Program, being kind of the leader in the forefront of invasive fetal cardiology, how did it get started?
So I think it's interesting because it actually started very differently from most fetal intervention programs, in that the cardiologists came to the maternal fetal medicine individuals and really presented them with the idea for this is what they thought was going to be the physiology that could be changed, and they had their thoughts as to how to get there. And we looked at the images, and our focus was really trying to move it to be a non-invasive, minimally invasive procedure. So at the time, which was more than 15 years ago, most of fetal surgeries were done as open hysterotomies. And so that was the initial proposal, was that we come and be able to see the fetus and then place the catheters like they would do in a newborn. When we looked at the images, for us, it was very much in the wheelhouse of maternal fetal medicine, who do ultrasound-guided procedures.
Okay. Do you remember when you actually did the first case?
Actually, do remember one of our first successful cases was actually 9/11. It was 2 days after 9/11. So it's always easy to remember that one. As we started doing these cases, we did them in the main OR of the hospital, large teams of people. We were all getting ready to go in, and they put our case on hold.
Wow.
And then we went ahead and did it 2 days later.
Awesome. Having really a well-established program, in your opinion, what does it really take if you're going to start up a new program with invasive fetal cardiology?
Yeah, and I think that's probably been one of the greatest treats for me in being involved with this program, is trying to bring together people who, in each of multiple different disciplines, are really very committed and very skilled in their own individual area. But then having to get all of them to work together at the table. And I think we've had the fortune to have a great group of people that have been very committed to doing this, bringing it through the IRBs, and really perfecting the tools that we use, as well as perfecting their styles. Meaning that for everybody who's involved, it's very different than the way that they usually function in an operating room.
Okay. So what lesions are best served by in utero therapy?
I think that, we started with the idea that for hypoplastic left heart syndrome, if we could intervene and open a critical aortic stenosis very early in gestation, that would have the benefit of allowing the left ventricle to continue to grow. And so that probably is the one that has the most support for doing interventions.
Are there any absolute contraindications to doing the procedure?
We have not done the procedure in twin gestations, with the idea that the procedure itself has risk. The overall risk of either the fetus being lost during the procedure because of complications at the time, immediately after, or rupture of membranes, preterm labor, is around 10%. Most of that is fetal demise, but if this were to be a fetus with a co-twin, then we have not taken on those risks for the co-twin.
So for a case of critical aortic stenosis, what is the best candidate for this therapy?
Yeah, so we've spent a lot of time trying to sort that out, since, as I'm sure you know, even when we are able to technically successfully open the valve, not all of the fetuses go on to be able to salvage their left ventricle. So we have spent time looking at different ultrasound parameters, I think that the criteria are that we want the fetus to have enough stenosis so that they've reversed their normal physiology. They've got left to right flow over the foramen, they've got reverse flow around the arch. So we don't want to intervene on fetuses who are not going to worsen. But yet again, if they've got a very shrunken left ventricle already with a lot of echogenic changes, then that's not going to be a ventricle that can recover.
Is there a certain gestational age window that the patient must be in to get this therapy?
Yeah, so we have like lower and upper limits, and I think our lower limits, I think the youngest fetus we've done has been about 19 weeks, and the lower limits are really just at the border of feasibility for the instruments that are used and the gestational age that the diagnosis is confirmed. And then our upper limits are 32 weeks. Essentially after 32 weeks, if the fetus is a candidate at 32 weeks with retained left ventricle viability, it's going to maintain that through the rest of gestation, and it wouldn't be a candidate that we would take those risks for intervention on.
Right. So are there any mandatory genetic studies that you say have to be done before you would take a patient to the OR?
That's a great question, because I think a lot of couples and women do ask that when they call. And we had made a decision early on that with counseling, we would not require that there be any genetic studies done beforehand, because that can lengthen the time. Even if you get a rapid study done, we literally see the ventricle change day by day.
Okay. Now, for somebody who's just starting out with a fetal program, I'm sure it's very different from where you are today, but what is the average time that you would have a patient in the OR to do this type of procedure, and maybe what could someone expect when they're just starting out doing the procedure?
Right. So I think that we have learned a lot along the way as far as how to decrease the amount of time that we're there, and we've learned that certainly we went initially from the early cases that we did them under general anesthesia, and we would do them under general anesthesia, and then again, as many things, everybody would talk and talk and talk, and then we'd scrub, and then we'd go back in, and the fetus would be so immobile from the inhaled gases that we really couldn't position at all. And so we've learned over time that we can easily move to neuroaxial, analgesia with a spinal usually, and not sedating the fetus any more than that when we do the initial versions, so that as obstetricians in doing versions, it's not all about just pushing the fetus around. It's sort of working with the fetus the way it's going to roll naturally, and so we want the fetus awake for that. We get the fetus into position. And that amount of time from when we start in the operating room to when we actually start our procedure, that can take up to 45 minutes. Okay. So we, at this point in time, have put a limit on how long we will keep trying to get a fetus into position. So we will try quite a bit with just planing the OR bed one way or the other, just to use gravity, and then we won't manipulate for more than 45 minutes. And I think we've seen that from looking at our results. Going longer than that, we have not gotten successes in getting position. Okay. And it's, with all procedures, very tempting to be just 5 more minutes. And I think from my perspective, one of my concerns is it's a fair amount of manipulation on the mother's abdomen, on the uterus, sometimes indirectly on the placenta, and we don't want to push that as far as getting an abruption. So we won't spend more than 45 minutes getting into position, and then literally once we're in position, if we are able to get in with a single pass and get across, that's another 5 minutes. Literally, it's very fast once we're in position, and then we always watch the fetus in the operating room for another 20 minutes.
Okay. When you do the procedure and the septos, or I guess the balloon dilation, that part of the procedure, how do you manage, the concept of fetal pain? And is there something that you do for that?
Yep. So what we do is once we get the fetus into position, before we start anything, is if they want genetic studies done, which we offer at the time, we'll go ahead and do those studies, and then we also will give the fetus an IM injection of narcotic medication, some atropine, and also a paralytic.
Okay.
So that by the time we come back in, the paralytic has worked. Hopefully the fetus is still close to the position that we left it in, and we're ready to go at that point.
And what precautions do you give to the patient after the procedure in terms of, I guess, maybe her activities or things she can or cannot do, and what kind of follow-up do you do of these cases?
Sure. So we traditionally have given them, the first 24 hours, we give them PO indomethacin. Although I would say the majority of them have not had any problems with cramping. We typically have them stay in the hospital that night. We have occasionally discharged patients home that evening who live in the area or have some place to stay in the area. They most often, though, the next morning, they've got an ultrasound that afternoon, they get an ultrasound the next morning, they get an echo the next morning. They're usually, able to travel back home again that next day. We generally have them take it easy for the next week.
Okay.
They can go back to work, depending on what their job is exactly. But the take it easy for the next week, quite honestly, is more, they've been through a lot. They've often made a decision very rapidly over a 2 or 3 week period of time. The couples are exhausted. They're really just wiped out. So we by no means have seen any increased rate of rupture of membranes, preterm labor by someone who's been very active. But it's more, get back home. This is the first step in a long road, and really, collect yourself. Go in and see your MFM or your obstetrician during that first week. They'll do an ultrasound. Make sure your cervical link looks good. Make sure the baby looks good.
So for open fetal cases, we know that we don't allow them to have a trial of labor. I assume that these patients can. And if they do you have a recommendation when you say they should go ahead and be delivered?
Yeah. So that's a good point, because these are all done with an 18 gauge or 19 gauge needle. And so just for perspective, amniocentesis is either done with a 22 or a 20 gauge. So these are, very, very tiny incisions, if incision at all into the uterus. It's really just the placement of the needle. So like amniocentesis, there's no restriction as to when or how they have to deliver. We certainly keep following them throughout the rest of the gestation. Some of the couples will relocate to deliver in Boston, though that's not required of the program. But if they're able to, and their intention is to have surgery at Children's, then we'll typically start seeing them around 32 weeks.
All right. And for those patients that don't go into spontaneous labor, do you have a kind of a cutoff to say it's time to have the baby, or?
Yeah. So mine is, I'm only laughing because there's so much support now for 39 weeks.
Okay, that sounds like a good cutoff.
And we really, it's not that we're any more concerned at this point in time about the baby, but 39 weeks, they've often relocated. They're living in temporary housing. I think there's no reason to keep going past an EDC in this case.
And do you have a sense of your cases that you have done, what the average or the mean gestational age at delivery is? Because obviously some probably do need to be delivered earlier for complications.
Actually, it's 37 and a half weeks. Yeah.
Excellent.
So most of it is weighted very heavily by the sharp curve up of 39.1, 39.2 induction.
Wow. And so how do you counsel someone, or what are your outcomes for the cases that you have done? Like how many, go on to have a single ventricle versus a two ventricle?
Yeah, and it's changed over time. So we've done now 160 cases, and certainly we have changed our criteria somewhat as we looked back on some of our outcomes. We're a bit more selective now as to who we think is really going to have a good outcome. We're actually in the middle of a study looking at what can we find in the amniotic fluid that can add to the ultrasound findings, because we have some input from the ultrasound findings to know that this is a good candidate based on ventricle size, echogenicity of the lining and the flow patterns. And then we found that BNP is a demarcator, so that actually reflects probably some stress damage, and troponin was not a marker, so not really infarct. But certainly those individuals that we think are good candidates, the more recent data that we have says that if we're technically able to get into the ventricle and to thread the wire, which we can about 85% of the time, then we expect 60% of those to go on to have a two ventricle
That's wonderful.
at delivery.
Yeah.
And I think we have to always caution parents too that certainly at times people will come thinking that I thought this was a much smaller procedure, and I thought it was always going to work. And so there is the risk that we can't get in because either of positioning, but I think we've been much more diligent in the last 7 years about making sure it's not an atretic valve. So the ones that we couldn't get across initially, they were really atretic, and we just couldn't get there. And then certainly making sure that they understand that once we get across, we have what we can say a technical success. So we can see change of flow right in the delivery room, right in the operating room. We'll see flow across the valve. We'll often see some regurgitation across the aortic valve, and we'll see forward flow around the arch. So that all makes us feel very good and makes them feel very good, but we really say this is the first very tiny step. And that, of those that technically get open, only about 60% are going to go on to keep the left ventricle growing.
Yeah. So other than, I guess, critical aortic stenosis, in your opinion, are there any other fetal cardiac lesions that might be amenable to fetal therapy?
Yeah, I think we have done, I think maybe around between 20-25 cases of pulmonic valve where it's very clear that hypoplastic right heart is delivering, but those cases are much fewer than come across the aortic stenosis. So many more times someone will get referred with pulmonic stenosis and it's not clear and doesn't meet criteria that it's actually going to progress to hypoplast on the right. So in those few cases we will intervene for pulmonic stenosis. Is a more difficult technique just because of the way that side arches off. The success rate is about the same once we get a successful dilation. And then the other one is that we started also initially with the right side is the hypoplastic left heart patients who are hypoplasts from the very beginning. A subgroup of those have an intact septum between the two atria. And so for those infants, we can't recover their left-hand side, but they're going to be critically ill right at birth. Right. And then the other thing which we've seen happen with those that have intact septum is their pulmonary vasculature gets very engorged and very full. And they seem to almost have a ultrasound pattern and then histological pattern, unfortunately, of very cystic kind of changes throughout the lungs. So that was one other lesion that we decided to go after was, though we can't open the aortic valve and recover the left ventricle, would we be able to change the outcomes for these critically ill infants by opening the septum?
Right. Oh, so interesting. So in closing, can you just give us your thoughts, I guess, kind of the future of invasive fetal cardiology? Where do you think it's going to become more expansive? Is it going to remain kind of focused on certain lesions in certain areas? Yeah,
I think we've had a lot of discussions about that. Where do we go next with this? What do we do? I think we still have a lot of work to do looking at the amniotic fluid and really trying to get a better handle on what we all know to be at least a half dozen different ways that a baby gets to hypoplast at birth, and trying to refine based on genetics, based on functional studies, who are the best candidates to really salvage for this. So I think that there's a lot of work to do there. I think there's a lot of work to be done in the area of neurodevelopment and cranial blood flow. The babies with hypoplastic left heart have the highest rates of developmental disability of all of the repaired congenital cardiac anomalies, and it's related to how their perfusion is in utero. And I think we initially held out great hopes that if we could restore their circulation, that we might be able to move that needle a little bit, but we really didn't. Granted, our sample size was small. It was around 60 fetuses and around 40 that got evaluated, and they were from the earlier cases. So I think we want to revisit that. You know, really the ones that have a solidly open aortic valve and change their perfusion in utero. Can we change anything about their development, either looking at biomarkers for development, looking at neurodevelopmental outcomes?
Wow.
And then lastly, I think there's a lot of excitement about the potential for stem cells, you know, in all areas of fetal therapy. And this is certainly one area that we've had discussions with the possible role of stem cells. So in the light of how stem cells have been used in adults and injected into myocardium for recovery of ischemic changes after heart attacks, whether there would be a role for stem cell placement, not intravascularly, because it won't stay there, but stem cell placement at some area at the time that we do dilation.
Wow.
So I think that's one area that we keep going down that path and following where the stem cell work really is, as far as its applicability, and then where would we best put those, and then how would we do that.
Oh, that's awesome. So on behalf of the Fetal Therapy Special Interest Group, I want to thank Louise for giving us this wonderful update
thank you for the invitation.
on invasive fetal cardiology. Thank you.
Thank you.